because I think SATs come down to nurses, and then they're left alone to deal with these patients that come out thrashing because they're delirious, and that really is hard and burdensome to the nurses. So when we create this environment, there's more support for the nurses. So they then lean on their rehab colleagues as like the delirium SWAT team to come in and help them. But if they keep sedation running, they're the gatekeepers. No one can go mobilize that patient because they're sedated. So you have to create an environment in which nurses have the knowledge, they know why they're doing this, they know how to do it, and they know who can help them with it.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Cyrus Askin, here as always with my good friend, Dr. Nick Mark. Nick, how are you doing?
Good. I feel like I just barely made it. My computer wouldn't power up this morning because despite having 4 USB ports, only one of them works for power and only with some USB cables. So basically I felt like I didn't have enough access. I needed to do a procedure to get more access.
How fitting. Yeah, no,
Indeed.
It's always funny how the best laid plans and all when it comes to recording. I'm never surprised by the latest and greatest in technical snafu that I'm encountered with. So
no, and there's nothing quite like that existential terror of oh my God, everything is on that computer. When did I back up? It's been more than 10 minutes.
Absolutely.
Anyway, everything's good.
So glad to hear that everything's good. Seems like we're ready to rock here. To that effect, Nick, what are we going to be talking about?
So I'm glad you asked. We're going to talk about a topic that we all take for granted ourselves outside of the ICU, but we often fail to consider for our patients in the ICU. I'm talking about mobility.
Yeah, I think this is another one of those topics that for us is tremendously important. Nick, you say this all the time. We love talking about blood and guts and airways and inotropes, but really this is a very patient-focused topic that, I don't think you can shout it loud enough from the mountaintop. So I'm glad we're going to be covering it today.
Yeah, surgical airways happen rarely. Mobility should happen on every patient every day. And so we are very lucky to be joined by an awesome guest to give us maybe a walkthrough, or maybe a run through, maybe a speed run through the world of ICU mobility.
Oh, well played. In just a moment, we're going to introduce her.
All right, let's jump in and introduce our guest.
Alrighty, so super excited today to have Kali Dayton with us. So she is a critical care nurse practitioner, and she's host of the Walking Home from the ICU and Walking You Through the ICU podcasts. She's also a critical care outcomes consultant. She is dedicated to creating awake and walking ICUs by ensuring ICU sedation and mobility practices are aligned with current research. She works with ICU teams internationally to transform patient outcomes through early mobility and management of delirium in the ICU. Kali, we are so grateful to have you here. Welcome to Critical Care Time.
Thank you so much.
Yeah, it's great to have you on the show. We're big fans of the work you're doing, and it's super excited to get into it.
So am I. I'm obsessed. This is all I talk about. So let's do it.
Nice. Well, I always like to start off by asking people kind of what got you into this, or what's your superhero origin story? So what made you so passionate about ICU mobility?
It started way back in 2012 when I was interviewing for my first job in critical care. The nurse manager asked me almost immediately, would you be willing to walk intubated patients on mechanical ventilation? And because I was so new, I'd never worked in the ICU before, I said, of course, I would love to do that, whatever that is. But you'll have to teach me everything. And then starting in that ICU, no one made a big deal out of the fact that almost every single patient was awake while intubated, and that we were walking them 3 times a day, or at least their highest level of mobility. It was just as optional and routine as giving an antibiotic. And I never questioned it because, one, everyone else just seemed like it was normal. Titrate the vasopressor, hang the antibiotic, do the bed bath, and then get them up and walk them around the unit, sit them in the chair during the day. They were writing on a clipboard. And it made sense to me because they're human. So I never knew anything else. Of course, they're going to walk, right? Yes, they're on a ventilator, but we just would increase ventilator support if they needed to. There were very few exceptions in which we would actually sedate them, such as intracranial hypertension, status epilepticus, the inability to oxygenate with movement. That practice was continued even during COVID. That's how established it was. They had done that for almost 15 years by the time I entered the scene in 2012. And I loved practicing that way, loved having those really intimate connections with my patients, seeing most of them successfully extubate, walk out the doors, that's what I came to expect out of critical care medicine. A few years later, I became a travel nurse. And no one really prepared me for the shock I would have when I walked through the halls on day shift and all the lights were down. Every single patient was in bed, pretty much motionless, no real signs of life except the monitors, right? And I got my assignment, and one of the patients was intubated. And I went in to do my normal routine, which was to introduce myself, communicate with them, get communication back from them, do a neuro exam, and probably get them to the chair to wait for PT. And I couldn't because they were sedated and unresponsive. So I asked the orienting nurse, because again, it's my first day there. No one knows me. I said, can I get sedation off and get them up? And I was taken back by how taken back she was. And she said, no, what are you talking about? They're intubated, which made no sense to me because I had walked hundreds, if not more, intubated patients for the past few years. So I said, I know they're intubated, but why are they sedated? And she said, because they're intubated. And I said, but why are they sedated? And we went in circles. And I finally had to back down, realizing, it was the first time I'd ever been exposed to the concept that a patient would automatically be sedated just because they were intubated. But it was also very clear to me that that was the common mentality. And when I would try to explain where I came from, they thought that those patients weren't sick, that it wasn't a real ICU, that I had worked in an LTAC. I got questions like, do you follow them with the intubation cart? And so I just kind of gave up on even trying to explain it and just went with what was normal. I also assumed that what was normal was benign. If it was really that bad or dangerous, they wouldn't do it. These were good people I was working with. Many of them had years more of experience than I did, so it must have been okay. I did notice throughout the next 2 years of traveling through many ICUs that my career fulfillment went down, that it was hard to work so hard on taking care of these patients that seemed to do very poorly. And after a few years, I returned to that first ICU and almost had another level of shock to realize I wasn't crazy. These really were sick patients, multi-organ failure. There's a bone marrow transplant unit in the hospital, homeless shelter or shelter for the unhoused down the street, lots of comorbidities, the dump station for the entire system, almost an unofficial ARDS unit. So I was walking patients on a PEEP of 18 and 100%. And I just realized objectively, these were much sicker patients than the ones I'd been treating in other facilities. We were doing a lot more with them, and they were doing better and extubating and walking out the doors. And I had a lot of questions. So it led me to dive into the research. Even while I was in my doctorate program, no one was talking about this. I had to look into it all myself. And it led me to see this huge problem within our system. And over the past few years, I've been trying to create solutions.
Man, I love that. I think it's just so striking too that like you go somewhere and there's a culture there and you just sort of assume that must be the right culture. And it's very hard to go to a place and be like, you guys are crazy. You're doing this all wrong. You know, I would say that outside hospital that you describe is like the typical hospital, right? So it's like very hard to like go somewhere and try to convince them that they are doing it wrong, and you know better. That's got to be really, really tough, really frustrating.
No one wants to be or listen to that travel nurse that says, well, in my ICU, we do this, right?
Oh gosh, yeah.
And I also didn't know any of the research behind it. And really, this is about 2014, so some of the research hadn't even been developed yet. My home ICU had published a study in 2007 showing it was safe and feasible to walk intubated patients, even with a median PF ratio of 89.
Wow.
But I didn't know that. That's how little I knew of the research as a bachelor-prepared newer nurse. So I couldn't defend those practices.
Yeah, and I kind of wonder too if, even if you had that ammunition ready to go, if it would have made any difference. You know, sometimes these practices are so deeply rooted and the concerns are so ingrained that, like you said, kind of being the squeaky wheel, being the travel nurse that's kind of bringing all of this great data to the forefront, you sort of get cast aside, or, oh, she's crazy, she doesn't know what she's talking about. And it's just so funny to me, like, as you're telling your story, like you had this very unusual experience of seeing what right looks like kind of right off the bat, and then being kind of raked through the reality of many ICUs, which is patients are kind of barely distinguishable from corpses, with the exception of the monitors that you described. So yeah, really amazing. And I can certainly see why this motivated you to get into what you're doing now.
And Cyrus, you had sort of a similar journey too, didn't you? Where you trained versus other places where you've worked have been quite different.
Yeah, I mean, I think that's, I feel like, as Kaylee's telling your story, a little bit of a kindred spirit type effect here, because where I trained, we had a very busy, a robust ECMO center. I trained during the height of the pandemic, so our ECMO beds were all full. And routinely, you would see, once the patient got settled in, they were cannulated, everything was secure, and we were able to get them off of, a lot of the analgo sedation that would otherwise be prohibitive to movement. These folks were on tilt tables. They were, doing, knee lifts or knee, they were kind of walking in place, marching in place. And then we got them walking with, whether it was on the vent or with the ECMO cannulas. I remember, a couple of these folks were, I think there was someone that we had on on a stationary bike. We had someone that was shooting hoops, at various points.
Two-point shot or three?
Yeah. I think it was a half court actually. But
I think it's extra points when you're on ECMO.
Yeah, I think so.
Absolutely.
I think you kind of just win. But anyway, yeah. So I saw that, and of course, like multidisciplinary rounds were truly multidisciplinary, where physical therapy, occupational therapy played a significant role. And then, as I've kind of gone to other places, I wouldn't say that my experience has been quite as stark as yours, Kaylee, but I would say it's similar tones in the sense of like, having to really push the folks that should be mobility champions to kind of encourage mobility. And that's just like blows my mind. So yeah, I love what you're doing. And like, it needs to be like, again, screamed from the rooftops and the mountaintops and everywhere else you can find.
In 2019, the very end of the year, I had kind of a divine revelation that I was supposed to start a podcast. I barely even listened to podcasts. So I was just making it up, recording episodes, trying to capture the why. I was interviewing survivors of normal ICUs that had been sedated and immobilized. Those stories were shocking to me because I had barely heard those stories myself. I didn't really understand their perspective. If I had, I would not have just gone with the flow in these other ICUs. I interviewed my colleagues to kind of prove that we were doing what we were doing because people didn't believe me when I tried to explain it. I was interviewing researchers, and I was told that no one would listen, that this would be just a waste of my time to even talk about. Ended up being very relevant to COVID, even though it was a hard time to adapt these practices. But it has been amazing to see that this is reaching rooftops. It's going to international. I just interviewed a few weeks ago a team in Bangladesh that made drastic changes. Now their patients are awake right after intubation and mobilized at least 3 times a day. Their bed sore rates were astronomical, and now they're hardly existent. So it's been amazing to see that people really do care about this. They just need to know the why and have tools for the how.
I love that framing, and I completely agree. I think like hopefully we're at an inflection point where the sort of what's normal is going to change dramatically in the next few years. Because it needs to change. Kind of to that point, let's set the stage a little bit here and talk about why mobility matters so much in people with critical illness.
I mean, one day in the ICU, you can lose 2% of your muscle mass. You can lose up to 30% of your muscle strength or muscle mass within 10 days in the ICU. There is so much going on during critical illness. We're catabolizing our muscles at a rapid rate. There's a decrease in use, and then you add on sedation on top of it. Sedatives like propofol, that is inhibits the sodium channels. It's a mitochondrial toxin. You're increasing not just the muscle atrophy, but the muscle damage. So this is not just the kind of condition where you gradually increase your physical activity and regain that muscle mass. If when you have muscle damage, that greatly contributes to the long-term physical disability that happens after the ICU, which we know is post-ICU syndrome. One study found just recently that 66% of medical ICU survivors could not stand at ICU discharge. That number decreased to 36% 3 months after discharge. And of that 36%, they had a 4.2-fold increase in 1-year mortality compared to those that could stand. So we're really not looking at the muscles as a vital organ for survival, but they absolutely are. When patients develop ICU-acquired weakness, that increases inpatient mortality by 36% and increases their chances of not being alive in 2 years by 43%. So this is a life-threatening condition that develops under our care and oftentimes from our care.
I think one of the big problems is there's this sort of availability bias that we tend to look at survival as somebody leaving the ICU in the patients we care for, and we don't really know where is this person in 2 years. Like when we're very lucky, sometimes a patient will come back and visit, and it's kind of nice to see somebody, and often you don't recognize them. But in most cases, we never know. And so that lack of information on follow-up is really bad. And the other problem is that most of the studies that are done use endpoints like 28-day survival. And surviving 28 days, but then being dead at 6 months after being bedbound for all 6 of them isn't much of a win.
Right. Or some sort of composite outcome where it's like, you have to really take the time to separate, the wheat from the chaff and figure out exactly, how these patients are doing. I think, one other thing I kind of wanted to mention is this isn't, you kind of alluded to this, Kali, but this is not like an unusual phenomenon. And I think a lot of times folks, they envision the patient with ICU-acquired weakness as being someone who has been the kind of like rare bird who's been intubated for weeks and weeks, super, super sick. It's almost like a foregone conclusion. And so, the reality is there are tens of millions of folks annually that are admitted to ICUs and receive those intensive care interventions. Whole spectrum of illness there. And, from my research, as I was kind of preparing for this condition, which is pretty common. So someone who has sepsis with multi-organ system failure, which can manifest pretty early in their course, is associated with nearly like 100% of those patients are going to have ICU-acquired weakness. That's like, where else in the ICU does something happen 100% of the damn time?
But because it's not a number, we're not monitoring muscle mass on the screen or in our AM labs, we don't care about it. And because it's so common, we don't see it. It's like trying to explain water to fish. It's all around them, but they don't recognize what it is. And so what's been impressive for me is to listen to these podcast listeners. Once they hear the podcast and they see it, now they can't unsee it. They just realize just how prevalent it is in the ICU. And it's almost like a moment of panic to say, wow, not only did I not see it, I didn't realize how much we could do to combat it. We're never going to 100% eradicate it. But to consider that on top of sepsis and these conditions that cause it, we are also adding on sedatives, poor nutrition, immobility on top of that, and destining our patients to have it and increasing the severity of it, as well as far delaying the rehabilitation from it.
Those are great points. I love that, fish can't see water point, that like when there's a universal problem, it's really hard to get people to see it and act on it. And I completely agree. We don't have a blood pressure cuff to measure your strength, right? So it's like without quantifying it, we don't care, right? We care about numbers. We don't necessarily care about abstract things.
Something that I notice when I'm on site with teams is we especially don't think through the muscular system during SBTs. So I see a lot of reporting, if that, of the criteria that was not met during SBTs, but no one is saying, okay, do they have low lung volumes because of diaphragm atrophy? Do they have tachypnea because of respiratory muscle weakness, none of that. And so how we oftentimes respond is, we're in rounds and the RN probably says, the SPT failed this morning, so I turned the sedation back on, and everyone says, okay, we'll try again tomorrow, and they shrug. Instead of thinking
I don't allow people to do that. Like, you can't report that you failed an SPT. I want to hear how you failed, which parameter, and why did you fail?
Right. Yes, exactly. And that's very rarely. I was just with a team that had a great reporting system in which they actually gave the full numbers. A lot of times I don't even get that in these teams where they report all the numbers, but there was no further critical thinking, no collaboration. When most of these patients have failed, it was because of weakness. It's because it's day 8 and they have not even sat at the side of the bed, and they're oftentimes delirious as well, but they turned off the ventilator essentially and the respiratory rate went up. They switched the mode back over and oftentimes resumed the sedation when they needed pulmonary toileting. They needed to re-engage those muscles. They needed all of this rehabilitation, but then we don't do it because we're not valuing the diaphragm as an essential muscle for survival and for liberation. When we really need to be thinking about the muscles on day 1 when they come in, just like we think about the kidney, right? We're going to be thinking, oh, they have critical illness. That is a vital organ for survival, and it's vulnerable during critical illness. Same perspective for the muscles as well as the brain. As these muscles atrophy, they're releasing inflammatory markers into the bloodstream, which are hitting that blood-brain barrier and increasing brain damage, essentially, this neurodegeneration. And that also is part of the water that we're swimming in that we don't see as well. And so we're having a lot of gaps in our knowledge that impair our critical thinking.
Yeah. It's funny too, because I as you were kind of going through that, and the frustrating thing, I think, is that the tools do exist. We may not have the most robust toolbox when it comes to assessing these things, but I know that, like Paul Wishmeyer, when we talked to him, we were discussing metabolic carts and using those to sort of ensure that we're appropriately feeding our patients. Well, there are plenty of tools available to assess strength, to assess muscle wasting, whether that's your diaphragmatic ultrasound or some of the other imaging modalities that are available, and yet that is so rarely done. And so it's like, why, to kind of your point, it's like influencing, being a social change agent or being a medical change agent, influencing your hospital to say, okay, well, part of our admission is going to be within 24 hours, we're going to acquire these baseline metrics and then we're going to track them. But I don't really see that done in the community.
No. And if we think about it, it's usually after they have a tracheostomy and
right.
LTAC is full, and now we're realizing, okay, well, then what are we going to do with them? I guess we get to liberate them from the ventilator. So now let's get therapy in. Because, we could talk about scope of practice and whose role it is to mobilize these patients, but this is just what's culturally happening, is that it all comes down to therapy. But also, oftentimes we don't allow them to access our patients until ICU-acquired weakness has already happened.
Right. We view it as a treatment for, as opposed to a prevention of.
And I don't dislike the term rehabilitation. In many cases, it can be unavoidable. I would like us to focus on prehabilitation.
Love it. Yes. It's one of my favorite things to talk about.
ICU-acquired weakness and delirium, focusing on that at day 1. So in my home ICU, the time frame was within 12 hours after intubation or after admission, unless there's a contraindication. That was the norm. So right now in most ICUs, we have this conveyor belt of intubate, sedate, and then once we're doing SBTs, now we'll do SATs, and now we'll start thinking about mobility, probably after they're extubated. But the conveyor belt in my ICU was intubate, wake up, communicate, mobilize, unless there was something exceptional happening.
Right.
And so that actually ended up making it much easier. I think what we see with in the ICUs is that now when we're rehabilitating patients, instead of taking 1 or 2 people to get them up to the chair, to walk them around the unit, it takes 4 or 5 people to sit them their flaccid body at the side of the bed. So
the Hoyer lift too, usually.
Yes. Oh, and the Hoyer lifts. Right. And we'll talk about level of mobility because I have so many thoughts about how we use our lifts.
Yeah.
But all of it reflects a lack of prioritization and value of the muscle system.
There's just one other thing, as you're saying that I was thinking of, is like all of the tools that we're talking about that we're using in the ICU, generically it's life support. So we should be supporting life. It's in the name, right? So in what world does life consist of, neuromuscular blockade, heavy sedatives, heavy analgesia, you're laying in bed, you're atrophying? Like, that is not, to me, I get it, fully understand that there's a time and place where you just have to save someone's life. And maybe that's not the time to get them walking around the ward.
Right.
But many times that's not the case. And are we really supporting life, or are we just kind of sustaining a pulse and sustaining breathing to the exclusion of what that patient really needs when they leave the ICU, to Nick's point, 28 days, 90 days, 1 year, et cetera, et cetera.
And we do think about that, but it's towards the end.
Right.
Once maybe the acute process is resolved or doesn't resolve, and now we just have this flaccid body in the bed that we're doing all the work for, that has developed pressure injuries, that when you turn sedation off, they get to tachypnic because they can't breathe and or they're really delirious. That's really hard for us as clinicians to see, causes a lot of moral injury. And then I think there is a sense of recovery is not likely. So now what do we do? But we can't ask the patient what they want. Now it's up to the families. And so now it's, we create all this turmoil when day one, we could have been asking the patient what they wanted. We could have been giving them the best chance to avoid all of those other complications. There's just so much that changes when we change what we do day one.
Yeah, I think that's really important. And I think on one hand, it is great that we sort of have normalized this culture of daily awakening trials and daily breathing trials. But I think the fact that those two are sort of tethered together is also a problem, right? Because it's sort of like, oh, I guess we're going to wake this person up for 30 minutes once a day. And that's not right.
There's a lot of history behind the bundle. In the 1990s, we didn't have any of this. We were giving benzodiazepine drips, opioids, paralytics for weeks. We didn't know the harm of those things. It just became the norm, in large part because we were experimenting with ARDS interventions, and we were giving 12 milliliters per kilogram in tidal volumes. So it kind of was unavoidable to have to deeply sedate these patients because, of course, they couldn't comply with the ventilator and be calm with these antiquated ventilators, 7 endotracheal tubes, and 12 milliliters per kilogram. Dr. Wes Ely made this astounding discovery that when you turn off the ventilator every day, they get off the ventilator much sooner. So that was in the late 1990s. And then about 2008,
Can I just jump in for a second there? I saw Wes, friend of the pod,
Yes.
did a great episode with us in season 1. Listeners should go back and listen to that if they haven't. I was talking to him the other day, and he just sort of dropped this like mind-blowing fact, which was he came up with this idea of breathing trials, which somebody suggested you should call them spontaneous breathing trials. So it became SBT. He did this like as a chief resident. So like anyone who's like, oh, like resident research never amounts to anything. It's like, dude, this guy came up with the SBT. Like, this is like foundational ICU care.
It seems so logical, but it really didn't exist then. They would just go on and on and on with all these sedatives. And then when they're trying to standardize that, they realize, well, obviously you have to take sedation off. You have to wake them up. So 2008, Dr. Gerard publishes the Awakening Trial, SBT. Around that same time, they're also realizing how lethal benzodiazepines are. So they add in this other prompt to choose wisely the sedatives that we use. So the ABC bundle. So that's really framed in the early 2000s. This ABC bundle. Then we were also doing delirium research, realizing how beneficial mobility was. So it grew into the 2010s into the ABCDE and then A to F bundle. But the mentality has kind of remained in the early 2000s of the ABC bundle. As long as we're trying to avoid benzodiazepines and turning the sedative off every day, quickly switching the ventilator off every day, we check that box and it's done. And these words that are used with SATs like holiday, interruption, break, vacation, they all imply an assumed resumption, that it's all temporary. The objective is seen as we're turning the sedative off to see if they can breathe on their own. And when we see that they can't, of course, we're going to resume. But also we put the failure criteria for SATs as agitation. but there's no specification as to what is agitation. So what I'm seeing is a lot of RAS plus one, restlessness, being called agitation and justifying the quick resumption of sedation. And that's what I learned in 2016. In one of the facilities that I worked at as a travel nurse, I was told, here we do this annoying thing at 5 a.m. You have to turn sedation off. And once you start to see them move all four, that's how you know they haven't had a stroke. And when they look uncomfortable, you turn it back on because you know that they cannot tolerate the ventilator. Mm-hmm. And that was one of the pilot hospitals for this 2019 ADF bundle study that was published. But that's what they had learned just down the pipeline through the telephone game as to what these SATs, SPTs were. And that's the way I was taught. And here we are in 2025, and it's still being practiced that way in large part.
Yeah, I think that's a great point, which is that it doesn't matter how many letters we tack on to the end if we're not doing the first letters right.
Right.
And I know, I think you and Wes have like a sort of a streamlined approach to it, like kind of a way of framing it instead of like all the letters. Like,
well, Wes had visited my ICU way back in the day. So he'd been doing all this delirium research, and he met Polly Bailey, who was my mentor. She was the nurse that started this process of care in the 1990s, just following her instinct, experimenting. And so she already had almost all her patients awake and walking. And so she met him at a conference and said, love your research. You do a great job identifying the problem, but what about the solution? We're always talking about the problem. Well, what are we going to do about it? So he visited her ICU, and he talks about it in his book, Every Deep Drawn Breath, that he was astounded by what he saw. And he realized this is what we should be doing at Vanderbilt. Dale Needham from Johns Hopkins visited Polly's ICU as well. And Polly went and visited theirs and said, turn sedation off, just went room to room and gave them instructions and taught their nurses how to do this. And so they wanted to create a bundle to guide clinicians to replicate Polly's ICU in that process of care, an awake and walking ICU, which, just so everyone knows, I define an awake and walking ICU as an ICU that only gives sedation when there is an indication for sedation. And when there is an indication for sedation, we give the safest sedatives at the lowest dose for the shortest duration possible, and patients are promptly doing their highest level of mobility unless there's a contraindication. And there's open family visitation. Families are part of the ICU team.
That's huge.
And that's what the bundle really was trying to point towards. The Polly Bailey method is what I call it. But we still try to hang on to those old practices of the 1990s, the 2000s, that automatic sedation, and then try to move towards the future. And it just didn't work, especially when we hit COVID. We slid back into the 1990s. So we have to revamp our perspective of the bundle. It's not just a quick on and off switch of sedation. Instead, it's to keep patients as awake, communicative, autonomous, and mobile as possible. So when I train teams, I have them memorize and repeat over and over again those 4 words.
Yeah, I like that. I like to sort of ask myself 4 questions. Are they awake? Are they out of bed? Have we turned off the ventilator? And where's the family?
Yep.
That's awesome. Hey, Kaylee, before I want to get into the granular stuff.
Yes.
Because I think our audience really wants to hear that. But one other thing before we do that is kind of still in the name of granularity, I suppose, is cost. And I think you might have discussed this in one of your podcast episodes, at least, or perhaps other ones. I think episode 95 was the one that I went across, where you talked about kind of the financial burden of kind of excessive sedation, what that cost is. So when I did some digging, it was hard for me to really find good data related to specifically ICU acquired weakness, which we didn't define it, I guess, per se. But for our listeners, one of the definitions I've come across there is bilateral symmetrical limb weakness or neuromuscular weakness that's really a clinical manifestation of critical illness polyneuropathy, not related to something else. So not like a Guillain-Barré or something else. So it's really related to that ICU stay.
Polyneuromyopathy.
Sorry, polyneuromyopathy. Excuse me. Thank you. So with that definition in mind, I kind of tried to find data. I really couldn't find very good data. But I was curious, Kaylee, if you could maybe, based on what you've come across for our listeners who may be interested, what do we have any idea what this is costing hospital systems?
So there is a study from 2015, I think, showing that ICU-acquired weakness increases cost by 30.5%. Huge. Another study showed I think it's from Dr. Inouye in 2009, I think. And I'll put all these citations in the notes, but she showed that one episode of delirium increased hospitalization costs by 39%. We do have a study from 2019 showing that the ADF bundle decreases costs by 30%. Now, my question always is when I look at these bundle studies is, how was it performed? Because there's such a spectrum of compliance with the bundle. There's fully awake and walking, and then there's doing SATs, SBTs, but any level of compliance improves outcomes. Every 10% improvement in compliance decreases inpatient mortality by 15%. Now, we don't necessarily have that for costs, but we do see that in some studies. For example, a recent study from 2023 showed that their ADF bundle rollout decreased their costs in one ICU by $5 million. That was Dr. Julianne Barr, but they still were not aggressively doing mobility. So it depends on the team's baseline. So I oftentimes ask teams, are you still using Versed as a common primary sedative? And if they are, that kind of tells me what year they're in. Okay, so you're still in around 2006. So I oftentimes see that the mobility is lacking. That's a sign that we're delayed in our compliance. If they're rarely sedating their patients or using a lot of prosthetics, oftentimes there's more mobility happening. So I can easily take that team to somewhere higher, and we do save costs, but it's a lot more drastic when they're doing Versed and no mobility versus now awake and walking. Teams that I've trained, one hospital had 2 ICUs, and within the first 3 months after training, they saved $500,000 just in direct costs. That doesn't include readmission rates, which one study showed that early mobility decreased readmission by 56%.
Which hospitals are being penalized for in many cases.
Right.
So it's not only it's that they're losing money because of readmissions that they could have prevented had they implemented mobility. Depending
on the diagnosis.
Right.
There's a lot of gap in what they're being held accountable for. Yeah.
That's a great point.
So yes, we know we have enough data to show that this does decrease costs, and it certainly validates an awake and walking approach being cost effective. I just don't think we fully captured the magnitude of impact that this has on the hospital's bottom line.
And we could talk more about this in a second when we talk about like the nuts and bolts of mobility. But I think one frequent point of pushback that you hear from people is like, that's great, but I don't have enough staffing to do this. And I think, for the 1 or 2 hospital administrators who are listening to this podcast, I just want them to take away that they could afford a lot more staffing if they implemented this. This pays for itself.
Huge.
It pays for itself because you're not spending that extra $50,000 per patient with prolonged length of stay. You're not getting hit with that readmission penalty. And because you're getting somebody out of the ICU, you can admit somebody else into that bed. So the opportunity cost is, you get to take care of 2 people instead of 1. So if you're a bean counter listening to this, you should be thinking, how can I hire more people to do more mobility? Because it will pay for itself.
Mobility techs are a huge bang for your buck. I've had hospitals hire numerous mobility techs, and they just over 20x their investment. It's insane how much money they save with this kind of investment. And it's really hard when I pitch to hospitals because sometimes they've recently downsized their rehab department because they didn't understand this big picture. They thought they were saving money and really it increased costs. So we need to be using this information to have these discussions to advocate for safe staffing. It's one of our strongest cards to play.
Yeah, I think that's really important. I'm glad we had an opportunity to talk about that because I think our goal with this podcast is people listening to this might be able to, broach these topics with their hospital leadership. And as we know, unfortunately, even though everything you're talking about is clearly in the best interest of the patient, being able to make that dollars and cents argument is important. So I'm glad we had a little bit of an opportunity to cover that.
And with staffing, there's a perception that an awake and walking ICU requires one-on-one staffing, copious amounts of staff, because it's going to take a whole army to mobilize them every single time. And that, in my experience and what I'm seeing throughout these teams that I've trained, is just not the reality. When people imagine early mobility, they're thinking about getting delirious, weak patients out of bed with all this equipment 8 days after admission. When what we're really working towards is having patients preserve their baseline mobility and their cognition so that they can move themselves. For example, in my COVID ICU, A lot of these patients were a standby assist, meaning that the nurses could be in these isolated rooms by themselves, just holding the tubing while the patients got themselves from the bed to the chair. But that wouldn't have happened if we waited until 5 days later to even do an awakening trial. So it's working more efficiently. It's also a skill set for the team. So when I train these teams, they'll email me and they'll say, it took us 30 minutes to get someone to the chair. We cannot do this. And I say, okay, time yourself next time. And the time after, and the time after. And it's like pronation, where it took 8 people, 45 minutes, everyone's sweating it out. We had some tube dislodgements, right? But then now I ask teams, how many people does it take? And they say 3 in 15 minutes. So the same thing happens with early mobility. So hospitals need to give the proper knowledge, training, tools, and staffing that give teams the time to figure this out. But down the road, it becomes much more efficient because all the things we listed. I also think we should talk about delirium.
Yeah, we should talk more about delirium.
Yeah.
I mean, I think that's, these are sort of like, the hand-in-hand problems, right? That like a lack of mobility feeds into delirium. Delirium feeds into lack of mobility. So, I mean, it's certainly a self-reinforcing problem. Let's circle back on that point, because I want to get down to the nuts and bolts of mobility first.
Okay.
So maybe we should just define some things. So like, what is mobility and what is early?
Mobility in the ICU should be active mobility. When you look into the research of early mobility throughout the last 2 decades, it can include anything from passive range of motion, lifting to the chair, to walking. And so when we're developing a mobility program, it should be active mobility. When I visit teams, I'll even hear physicians that are well-intended and on their best behavior saying for every single patient, okay, let's lift them to the chair. Let's sling them to the chair. And that's really not what mobility is. That does not preserve muscle mass. That does not engage the brain. I even had...
It's not us moving them. It's them moving themselves with our help.
Exactly. So equipment can be needed, but that equipment should be facilitating their highest level of mobility and the safety to do it, but it should not be replacing their engagement. Otherwise, it's not beneficial, and it still takes a lot of people. It still can take 3 people to sling someone to the chair, where we could use those 3 people to sit them at the side of the bed, where they have to hold their own heads up, engage their core, and start to engage with reality and work through the delirium. So it's really needs to be highest level of mobility, whatever that patient can do, which if we're doing it early should be their baseline. We should be focused on preserving baseline. If they've already lost ground, then we're meeting them where they're at and pushing them to regain their baseline mobility. And then early can also be very variable in our research, from within 2 days after admission to within any time they're in the ICU, right before they transfer, within 14 days. So looking at the timing of our mobility is imperative. We know that patients have to be mobilized within 72 hours after ICU admission to have any impact on post-ICU syndrome. The studies that show the most benefit with early mobility happen within 48 hours after intubation. So I'll oftentimes have studies thrown in my face saying this didn't show any benefit, but then we have to look at, well, when was the mobility implemented? What was the dose? What was the frequency? What level of mobility were they doing? If we were just slinging them to the chair 5 days after intubation, well, yeah, you're right. It didn't have any impact. So we need to be really specific about how we are implementing early mobility in our teams.
I think that's a great point. And I think you notice this in a lot of studies, that they use sort of a pragmatic research protocol where it's basically designed for, like, we don't have staff 24/7 to do this research project. So if somebody comes in on a Friday night, we want it to be okay that they don't get anything until Monday morning, right? Which is like a pragmatic thing you do as part of a trial. That's fine. You have limited money, but that becomes like a normal acceptable standard, and it shouldn't be. Right? It shouldn't be okay to wait 3 days to begin something that could start much sooner.
Well, we see this in the team trial as well. This is a recent study published in the New England Journal of Medicine in 2022 that made a big splash in the community because it was looking at the dose of mobility, seeing if higher dose would have better benefits. And it did not show any impact with a higher dose. But looking at how it was done, the methodology, which is really important but often overlooked, these patients were automatically sedated after intubation. Their median RASS was -3 for the first 6 days. Then they did sedation interruptions for mobility, pretty low level mobility, mostly sitting at the side of the bed. And then they don't specify whether or not sedation was resumed, but they called it an interruption. So in a normal ICU, they were probably immobilized fairly passively, and then sedation was resumed. Because that happens. You'll have someone awake during the day, and then they get re-sedated overnight. Then the next day, you're having to clear out the propofol hangover, and you're doing a lot of the work for the patient. And so that just shows that even in our best studies, the best well-funded studies, the most progressive units, we're still automatically sedating, waiting until 6 days later. And there was only a 12-minute difference in the amount of time spent on early mobility with these patients. So there really was not much contrast between the control and intervention.
So out of
group.
24 hours a day, the high intensity was 12 minutes more than the standard intensity.
Correct. 6 days after.
Right. So a relatively low dose administered way too late with all the usual flaws that we talked about. Yeah.
Yes. And you think about, I'm always thinking about how propofol is a mitochondrial toxin. So you're doing all this work to try to, quote, rebuild muscle, but then you're giving a mitochondrial toxin. After that, it also, again, decreases the muscle excitability. So you ask any physical therapist that goes in after propofol has been turned off and it's 2 hours later, an hour later, and they're still so sluggish, whether it's their cognition still impaired or their muscles are just not responding, it's kind of a waste of time. That is very different than a patient sitting in the chair writing on the clipboard saying, when's PT coming? I'm ready to walk.
And I think just to make one other connection that I think is important is, those 6 days, conservative estimates would suggest 5 to 6% muscle loss, conservative estimates.
Yeah.
Probably 10 to 12, 14%, right? More realistically. I think the recurring theme here is the fact that, the cat's already out of the bag by the time we start thinking about this. By the time we start having this discussion, you've already set yourself up for failure if you wait 5, 6, 7 days. And that is objective. There's no equipoise there.
But yet people will wave at my face every time I go to visit a team. Someone, usually a physician, brings that study up as a aha, gotcha. And they say, see, mobility does nothing. That's the conclusion that they get from it. And the written conclusion isn't too far off from that statement. Yet my conclusion would be, and thus we see that some low level of mobility 6 days after a RAS -3 was not an adequate rehabilitation with 12 extra minutes to recover from the damage done during those 6 days.
Yeah. The thing is too, as someone who's into exercise physiology and into weight training as a healthy person, we often talk about when we're coaching folks or training ourselves, the tonnage or like the dose. So the frequency, the volume, et cetera. And so just because a person is admitted to the ICU doesn't mean like all of that physiology just like disappears. So like I think what you're talking about, Kali, that dose is so important. Like just like the antibiotics, just like your vasopressors, that mobility and those sort of like strength maintenance or strength training initiatives that you do in the ICU, they have to be dosed appropriately as though the patient were out and about kind of doing their thing. Obviously, you're not going to have the person, bench pressing 225 while they're laying on their back. Unlikely anyway. But the principle still remains the same, I think. I think that's what I'm kind of getting from this.
And I invite everyone to listen to the episode that we did with the wonderful author, Carol Hodson. She put together this huge study. It was well developed. I don't think they expected there to be such a minimal contrast between the two groups. We'll put the link in the show notes to that episode. She was a great sport as Wes Ely, Heidi Engel, and I kind of nitpicked it apart, but there was certainly a mentality in other conferences that I've attended since then that this was the optimal level of mobility. You just can't improve upon perfection. I also then wrote an article with a great group of experts where we took a case study from my home ICU and compared that to the team study. And it went just day 1, day 2, day 3, and how these patients would have been treated differently in the team study versus an awake and walking ICU approach. We called the team study at less than 50% compliance with the A to F bundle. And an awake and walking ICU was 100% compliance. And after 17 days of mechanical ventilation with severe ARDS, PEEP of 18 and 100%, this guy walked out of there cognitively and physically intact and went right back to work.
So let's actually get into that. I think that's a perfect segue to talk about like what does mobility done right look like? So like hypothetical, somebody rolls into the ICU, they've just been intubated for hypoxic respiratory failure, they've just been brought upstairs from the ED. What does the first 12 hours look like?
They are promptly awake, given a clipboard or a cell phone, and able to communicate. Respiratory therapy, the pulmonologists, intensivists have helped manage the ventilator so that it's working for the patient. Not that we're trying to make the patient work for the ventilator. We're treating their air hunger, their pain, their anxiety, the families at the bedside, and they're telling us what they need, and we're meeting those needs. That's much easier day 1 than day 3 when they still have the cognition and fine motor skills to use those nonverbal communication tools. Then, depending on what time they were intubated, if they were intubated at 3 a.m, probably 9 o'clock in the morning, we're getting them up to walk if that's what their baseline mobility was. If they were in a wheelchair at baseline, we're sitting them at the side of the bed. Maybe we're using a verticalization bed, but we're preserving their baseline mobility. As long as they can oxygenate with movement and they're hemodynamically stable, even on vasopressors, if we're not drastically increasing and adding on more vasopressors, and they can sit up at the side of the bed and they still can perfuse and they still can oxygenate, then we're going to see how they do standing. And we're going to recheck and see how they're doing. Then we're going to march in place. Then we're going to start to take some steps. And then we're just going to roll if they're ready to go. So we're doing it progressively, monitoring as they go, maybe having a wheelchair behind them in case they need to take a break. But that's going to be safer than in 6 days from now, when now they are so weak and deconditioned at high risk of falls. They're going to be at risk of orthostatic hypotension. They're going to be confused and at risk of pulling out their endotracheal tube. Doing it day 1 might take 2 people, maybe 3. The family member can push a wheelchair. So 2 clinicians for 15 minutes rather than 45 minutes in 6 days with 5 people.
So you read my mind. I was going to ask you, how many people does this take? And, who else can you use? So exactly, right.
It also depends on the team, right? So
yeah.
In an ICU that's done this for a long time, they don't necessarily need RT there every single time they sit someone up at the side of the bed, because they know how to do inline suctioning. They know how to assess. Certain patients don't need a lot of adjustments. Other patients might, but they are better at triaging who they need. Obviously, if they're going outside the room, they need RT, but a lot of times they can do stuff within the room without needing RT. But starting off with, when it's so new and everyone's so nervous and they're developing their skills, they need those extra people and that extra time.
Yeah.
Excellent. All right, let's talk about some of the stuff, because I think sometimes we get a little bit fixated on equipment instead of training. So what are some of the tools that the people in ICU need in order to mobilize people effectively?
Obviously, walkers, platform walkers, normal walkers. If their ventilators cannot be transported easily, transport ventilators. Some people like to use walking harnesses or that can connect to the ceiling lift. Verticalization beds are an absolute must. Anytime I train a team, I tell them to hit one of the companies that make those. There are 2, and make sure that they pick out a bed and have it ready, because that can open the doors for so many patients that are of higher complexity, so that we can start bearing weight sooner.
So for listeners who don't know, do you want to explain what a verticalization bed is?
Yeah, we've had tilt tables for decades, thinking about a lot of our cardiac population and orthostatic training, but we can use it in a lot more contexts, and it's a lot easier when now we have beds that become tilt tables. They're normal hospital beds, but they have 3 very secure straps that can go onto patients, and you can tilt them. So even if they're having seizures and they're deeply sedated, you can have them standing up at 40 degrees, 60 degrees, bearing weight and preserving that proprioception, those large muscles, and preparing them for mobility once they are off sedation. If they have severe ICU cord weakness, there's just so many indications for it, but it's essentially a tilt table built into a normal hospital bed. So you don't have to transfer them to the different devices. You can now have easy access for one person to stand someone up frequently throughout the day.
Yeah, I think these are a game changer. And, like, as you point out, they're not really new. Like, we've had them for a while, but I think they're being more widely used. I used to joke that they were like, those old movies where like the vampire kind of like springs up out of their coffin.
Yep.
It kind of looks a little bit like that.
It feels like it too.
It's great. Yeah, but I mean, it makes one person able to get somebody up. It makes it much easier. People can go from flat to up to step off. So it's like another way to transfer in some people, like people who have like cannula that might be hard to bend at the waist. Yeah, they're great. And as you said, like it makes it easy to do mobility many times a day, as opposed to that once a day sort of check the box session.
And again, frequency and dose is so important. We know in patients post-stroke, they need short and frequent mobility sessions. But when we just leave it to PT and OT, these patients with hemiparesis that the nurses are nervous to get up, that's not enough. So then now, not only do they have one side affected, their other side becomes very weak. So this is a way to have early and frequent weight bearing in both extremities and just jumpstarting the rehabilitation.
Excellent. And let's talk about the people now. So you mentioned you can do it with two people, maybe a respiratory therapist, maybe not, depending on comfort. One's obviously the bedside nurse. Who's the other person or the other two people if you have multiple?
It just depends on who's available. So if it's a physical therapist going in, the nurse can go in and help them, or their PTA or OTA or the CNA. And again, it depends on the patient, right? If this is someone that at baseline has a lot of mobility needs, maybe two people isn't appropriate. But for many patients, we can start doing it sooner. Right now, what happens in a lot of ICUs is PT and OT are co-treating because they're going in so late. And these people need so much support, just manpower, hands-on, but also skill. It takes a lot more skill to get someone up that cannot bear their own weight or hold their own head up. Now we can break up PT and OT so we can have more frequent sessions. So PT can go in the morning and OT can go in the afternoon. But right now, nurses aren't really taught that mobility is part of their practice and their stewardship. So they might turn therapists away at the door saying they're too agitated, they're too sick, they're too sleepy, they're too unstable, and that cancels it for the next day.
And I just want to point out that as a doc who works mostly at night, I think there's a lot of culture change here too, which is this idea that you don't need PT and OT to mobilize, right? They're like the black belt experts at this, but for a lot of people, you don't need it. A lot of it depends on what is your team's comfort. And as you pointed out, you can use people like CNAs who are trained and supported to do this. And what that means de facto is that you can mobilize people at night when there aren't PT and OT in the hospital, on weekends, on holidays. Like mobility is not like a daytime thing.
Yes, we need to see them as consultants. They're providing their expert opinion and guidance for the rest of the team to follow through with. And they're not a lift team. They're not the chair to bed, bed to chair service. So I, as a nurse working in the awake and walking ICU, oftentimes had my patients already in the chair waiting for physical therapy to come and do therapy. The therapy was not getting to the chair. That was just for patient comfort, right? That's how I could change the sheets. That's just because that is what you do when you're a human in the morning. At night, there's no PT and OT. So I would walk them around the unit with respiratory therapy, maybe a family member pushing the wheelchair, maybe a CNA pushing the wheelchair. And that was because that was in my scope of practice. And it was like an antibiotic. You couldn't just skip a dose for the night.
Right, exactly. It's not like it's not like we can only suction somebody when RT is in the room or only give an antibiotic when the ID consultant is there.
Right.
Like mobility is something that happens even without the expert consultants there.
Absolutely. But that does require that everyone have the training. And so for a leadership to go out and say, get it done, you will have a mutiny on your hands. And it probably won't be safe because they need to have the training on when to do it, how to do it, what equipment to use. It is a skill set. So just because it's in the RN scope of practice does not mean that it is part of the RN's current skill set.
Right.
So, Kaylee, that's awesome discussion there. And as you were talking, I was kind of thinking back to our nutrition episode where we spoke with Dr. Paul Wischmeyer and how, his approach to nutrition is essentially the same as what you're describing. It's like you don't wait a week to begin trickle feeds. You've already missed the boat and now you're underdosing. It's like it's a recurring theme, I feel like, in many ICUs as we focus so much on their septic shock to the exclusion of the person laying in that bed. So and then not to mention the fact that obviously nutrition and physical therapy and all that, they kind of relate. You have to feed the patient if you expect them to actually be able to perform or to maintain. But I did think that was kind of this interesting paradigm. It's like we just have this proclivity for missing the boat on things that are not like the, presenting chief complaint.
It's like we're too busy to save their lives.
Right. Exactly.
Yeah, right.
Exactly. It's the irony of that. So the other thing I, took away from this, I think, is it seems like once you get the appropriate training and folks are comfortable with this, really the best champion is probably the patient's bedside nurse. Like they're probably the ones that really need to be keeping the medical staff honest, keeping PTOT honest,
or their family.
Or their family,
is
of course,
a great.
Yeah. You're right, Nick, kind of in tandem, getting to the idea of self-efficacy, which doesn't stop in the ICU either. It sounds like depending on these consultants essentially is probably not the best way forward, just waiting for them to show up and save the day 10 days after admission.
You have to create a high reliability environment where it doesn't depend on which nurse is on, which attending is on, which therapists are on. It needs to be the expectation of the entire unit. So these teams that I train, we roll it out like a Foley catheter. We were looking at CAUTI risks. So now we look through, do they need the Foley? Let's get it out. And it's a standardized assessment. So yes, I think it needs to be nursing driven, but in that as well, it's not only nursing dependent.
Right.
Because I think SATs come down to nurses. And then they're left alone to deal with these patients that come out thrashing because they're delirious. And that really is hard and burdensome to the nurses. So when we create this environment, there's more support from the nurses. So they then lean on their rehab colleagues as like the delirium SWAT team to come in and help them. But if they keep sedation running, they're the gatekeepers. No one can go mobilize that patient because they're sedated. So you have to create an environment in which nurses have the knowledge. They know why they're doing this. They know how to do it, and they know who can help them with it.
Awesome. Yeah, I think that's very well said, Kaylee. So I think, in the time we have left, I know we wanted to talk about some of the myth busting associated with mobility in the ICU, and some points there that we discussed in pre-recording that I think we definitely want to underline. But before we do that, we talked earlier about PICS, or this post-ICU or post-intensive care syndrome, the relationship between ICU acquired weakness and delirium, and how post-ICU syndrome is both like it's a neurocognitive issue, but it's also kind of a physical issue as well, or kind of a syndrome, I should say, that folks deal with. So with all that in mind, Kaylee, I was hoping we could talk a little bit about the relationship between mobility initiatives, or the lack thereof, and delirium, as yet maybe another reason why this is so critically important.
Well, we see a huge correlation between bed rest and delirium, especially immobility and delirium. Again, as I mentioned, when the muscles atrophy, it releases inflammatory markers that hit the blood-brain barrier. There's also disrupted sleep, which is a huge risk factor for delirium. When we see the bundle as just an on and off switch for sedation, we don't mobilize them, we end up giving them more sedation. So if our focus of the bundle is for mobility, which in fact, I love what Heidi Engel, she's a physical therapist from UCSF, she says that we should switch it to the F to A bundle. So after intubation or early on in admission, our focus should be having them connected with their loved ones. That means that they have to be awake enough to do that. And then they're going to be awake enough to do early mobility. Then that's going to help us actually practice the D. If they're awake and mobilizing, they're going to be able to get real sleep, because sedation is not real sleep. It blocks REM cycle 3 and 4, at least midazolam and propofol do. And now we're actually able to assess, prevent, and treat delirium. Now we're actually choosing sedation wisely with that C. That C should also be choosing whether or not to sedate patients, not just what kind of sedation we automatically give. But if we're, again, focusing on the F first and the E promptly after, now they're awake. We don't have to do the awakening trials. They're ready for breathing trials much sooner. They can report their pain to us. So the rest of the bundle just falls into place. So we just can see that when we automatically sedate and we immobilize, we're setting up patients that have high risk of delirium. On average, they have 11 different risk factors for delirium. And now we're giving them deliriogenic medications, creating a deliriogenic environment, and we're destining them to have delirium, as well as increasing the severity and prolonging the duration of delirium, which is lethal.
Well said. Yeah, I think one of the things that is really important about mobility too is that it limits how many bad things you can do to somebody, because it's going to encourage a lot of good practices. So for example, like that Foley that they don't really need anymore, if you're mobilizing them, you'll be like, hey, can we just take this Foley out?
Yes.
Do we really need this? And, you see it in a lot of different things where it's just sort of like, it's sort of a ratchet that moves their care forward as opposed to like sort of staying where you are, this clinical inertia.
I mean, all the things that we worry about, COTIs, CLAPSIs, pressure injuries, all of those get better. We see in another study that a 300% increase in early mobility decreased hospital-acquired infections by 60%. So we have these isolated committees throughout many hospitals, but really the root of it is in delirium and early mobility management. In my wake and walking ICU during COVID, they had a COVID unit, one of the highest acuity COVID units in the state of Utah, and less than half of those patients had central lines because they were not sedated. Then they didn't get hypotensive, so they didn't have to run vasopressors for days. It changed the trajectory and the management entirely for most patients.
Yeah, so that's incredible, Kali. So just to kind of really foot stomp this and make sure that our audience appreciates the gravity of what we're discussing, how dangerous is delirium really and truly?
It doubles the risk of dying in the hospital. So does acute kidney injury. And yet, which one do we value more? The kidneys or the brain, right? So even 6 months after discharge, the risk of mortality is tripled. For every 1 day of delirium, there's a 10% increased risk of death. We need to understand that this acute brain injury can lead to long-term cognitive impairments that are at the same level of a mild Alzheimer's and moderate traumatic brain injury that can last the rest of their lives. It changes their ability to go back to work, to care for themselves, live independently, their family relationships. It just changes everything about their lives. It also is the main risk factor for post-ICU PTSD. So we have this culture in the ICU in which we think that patients are peacefully sleeping. And it's reaffirmed by the fact that when we turn sedation off, they come out with terror in their eyes, trying to self-extubate, really worked up, oftentimes very agitated. But when we turn sedation back on, they go, quote, back to sleep. They stop moving. And so it just feeds this belief that we're doing what is humane for patients, which when underneath, a lot of times patients are, what I've been told by the dozens of survivors I've interviewed is that they thought their deceased father was cannibalizing them. They thought they were kidnapped. They thought they were being raped. They thought there was a snake down their throat. They could hear and feel everything around them, but it was being twisted into something much more graphic and morbid and traumatizing than anything we could have done to them in the ICU. So delirium is part of the organ failure that happens in the ICU, but it can go days to weeks without being detected. I'm finding that a lot of our CAM screening is being charted as unable to assess. So we can look at an A to F bundle dashboard, which looks at charting compliance, and the D could have a 60% compliance, which is not great, but not as bad as some that I've seen. But when you break it down to positive, negative, or UTA, over half of them will be unable to assess. And even the positive or negative charting, I don't trust because I'm finding that clinicians don't actually know how to perform a CAM. They're thinking that if a patient follows commands, that they are not delirious. And so we're missing a large amount of this acute brain failure that's happening to our patients, drastically increasing their mortality and changing their lives forever.
Right. I think people often forget that most delirium is not hyperactive. Most is either hypoactive or mixed. And we're better, obviously, at seeing somebody who's screaming and shouting and saying they're delirious than we are at seeing somebody who's just staring at a wall. It requires more work on our part to assess them and determine if they are delirious. So, yes. And then, by the way, I mean, even if we're doing CAM assessments, once or twice a shift, that means we're not assessing them most of the time. And delirium, by its very nature, is fluctuating. So it's an imperfect way of measuring a fluctuating illness.
Until it becomes a number on the screen, it seems that we won't prioritize it.
I think that's very true. Yes, and I'll point our listeners to, it's a 2004 JAMA paper by Wes Ely, where they talk about these numbers for just how severe delirium is. This was like a real eye-opening paper for me when I read this, because I think before this I had this sort of naive oh, they're just pleasantly delirious or some awful thing that people say. And then afterwards I was like, oh man, this is an emergency. Delirium is really bad. We can't normalize this at all. This is a huge problem we need to devote significant resources to.
And I just recently had an attending say, yeah, but I think it's overblown. I've never had patients tell me it was that bad. Those are just the anecdotal stories. And to that, I quote survivors that say, of course, I wouldn't go back to the place where I thought I was sexually assaulted to tell them about it. It's way too triggering. I didn't feel safe enough to tell people about it while I was under their care. I wasn't physically capable of communicating. I couldn't talk. I was still so lost. So no, they don't know about it. So there's a lot that happens that we are completely unaware of.
It's that availability bias again that, we don't seek out, negative examples of the care we provided. So we don't hear about them.
So, Kali, being kind of mindful of the time we have left, I did want to get to some of the myths that are commonly discussed in the world of mobility. One of the ones that I really wanted to talk about, I'll be a little selfish here, is kind of fueled by this Zero Falls initiative, which I think is like a great blurb in out of context, but in my experience, it just fuels all of the problems that we've discussed. And so this idea of like, this patient cannot fall, I'm going to lose my job. And like mobility, it basically demonizes mobility. So can you talk to that and how we can, I think a lot of folks are going to run into that when they try to maybe like, turn the tide of battle here, is the Zero Falls sort of initiative. How do you approach that?
I mean, 75% of falls in the ICU happen in the setting of delirium. So you add in confusion on top of severe weakness, of course you're going to have falls. So true prevention is keeping patients strong enough to bear their own weight and cognitively engaged to understand that they're hooked up to all these machines or that they are too weak to move. But we create this delirium factory, as Dr. Wes Ely calls it, and we cause them to atrophy, and then we strap them in bed. And we do not let them rehabilitate. So we are creating falls. Now in the ICU, we may have lower levels of falls, but are we really seeing what happens when they go to the acute care floor or when they go to LTAC or when they go home? So that's been really enlightening for me to interview survivors, and they talk about their falls at home. Yet we thought in the hospital that it was a success. And when I go to conferences and I hear about these fall prevention initiatives that happened, my first question is always, did you also track your mobility levels? And not a single group or team presentation has been able to confirm that they did. So they're just looking at falls, but what oftentimes happens is that means that they're keeping them in bed more, they have more bed alarms, they're controlling their mobility more, which sounds nice in theory, but then they decrease mobility. And so then what happens later? And that also increases delirium, and it's dangerous. And there needs to be psychological safety. Same with self-extubations, right? We have this environment in which you are the worst nurse ever. You're going to lose your license. Your patient is going to abruptly die if they pull that tube out, when that's much more likely to happen if they've been given sedatives. Delirium increases the risk of self-extubation by 11.6 times. And then if we cause them to atrophy so severely that if they do lose that tube, they can't independently breathe, we've increased the risks. So we have to change our mentality and our definition of safety in the ICU to really consider the dangers of our normal, safe, quote, practices.
Yeah, I think you and I were talking about this before about, changing the focus from a culture of safety, nothing bad can happen, to a culture of outcomes, where we look at, kind of the more meaningful thing, like, are you living independently at 6 months? As opposed to, did a fall occur? Because these are all counterbalanced metrics, right? Having zero falls at the expense of substantially less mobility, and then you have way worse outcomes, that's a bad deal. But, to our point earlier, it's easier to count how many falls there were than how many people can go to the grocery store on their own at 6 months.
And I think we have to understand the perspective of nurses. As a nurse, I would work Monday day, Wednesday night, Saturday day, different patients every time. So I had this 12-hour snapshot. And my one job was to keep the tube in and keep them from falling and keep them alive. When I became an NP, and now I was working 7 days straight, and I was seeing more of a continuity and continuum of care, that changed my perspective that I wish I'd had as a bedside nurse. It would have changed how I approached their management. So we have to change that perspective and even have a better feedback loop as to what's happening to these patients so that we can carry that into the next patient that we treat.
Man, it's a huge point. Yeah, I know we could very easily achieve zero falls by putting everyone in 5-point restraints, bed alarm on,
slamming Ativan.
too easy, to do that. And
Index.
then, yeah, exactly. The neuromuscular blockade and all of that good stuff, quote unquote, good stuff. And, what we'd be left with is not an ICU problem, quote unquote. And I think that's what looks good on the metric. It's like, we need to recognize, I think, Nick, you said it really well. It's like, we need to recognize what the outcomes are. That's what we need to care about is like, these are patients who are going to leave the ICU and they're going to need to live their lives. How can we facilitate that? I think some of these other myths, that someone who can walk should be extubated. They should be good to extubate, or like we can't do this safely. Period. We don't have the staff to do it. I think it's just like feeds into this belief that the outcome is less important than the here and now.
Again, because our definition of safety revolves around patients being still lifeless, motionless in the ICU bed. We know that from a meta-analysis in 2017 that over 14,000 mobility events were included, and there was a 0.6% adverse event rate with mobility sessions in the ICU. Again, I mentioned my home team study, median PF ratio was 89, and again, a 0.6% adverse event rate. And sometimes in the team study, for example, there was very general definition of adverse events. And we need to classify and categorize what those are. So I also included a citation to an article showing we need to say high risk, low risk, moderate risk. We need to define, are they having a physiological response to activity, or are they actually having a high risk emergency during mobility and because of mobility?
Yeah, I think it's worth pointing out too that 0.6% risk with mobility is probably about the same as your risk for just that same amount of time in the ICU, right? Like there's a non-zero risk for every half hour, every hour in the ICU that you'll lose a line, you'll lose a tube, that, you'll desaturate. Right. So like when you measure those things during mobility sessions, you don't expect the number to be zero. You expect it to be whatever the baseline risk is. And 0.6 is quite low, right? I mean, that's actually probably about what you'd expect the baseline risk for adverse events to be in the ICU anyway.
And a Morris 2011 study showed that a lack of early mobility was an independent predictor of readmission and mortality within the first year after discharge. So again, changing what is unsafe for our patients.
Right. Yeah. And I think that's it's an important thing for us to do too when somebody is readmitted to the ICU, to sort of like ask ourselves why, like what did we screw up last time that they were readmitted this time? And often the issue is that they were not mobilized. They did not leave at a good functional status.
I have teams provide for me case studies, and I say just normal patients on your unit that are on mechanical ventilation, because that's a kind of a low-hanging fruit. And no outliers, nothing crazy, and I am easily able to pick out all the adverse events that happen because of poor sedation, delirium, and mobility management. One team a few months ago, I estimated 10 to 12 extra days on the ventilator, a VAP, stage 3 pressure injury, very likely had a fall after the ICU. I can't imagine how she didn't. Very likely readmitted between 2 patients, 10 to 12 extra days, and all of those complications because of their sedation, delirium, and mobility management.
That's crazy. It's funny because it speaks to a couple of, I was looking at our list of myths. It really, based on that, speaks to a couple of our myths. The idea that it's inhumane to have patients awake and walking with an endotracheal tube, or we should just let them sleep and rest. Well, sounds to me like it's inhumane to not do those things. Adding fuel to the decubitus ulcer fire, the VAP fire, etc.
And this is why I won't even go on site with teams until we've done thorough education. We've done webinars and we have laid a foundation of the why. Because it's impossible to have these conversations or to inspire a team to change or to give them tools to critically think through every single patient and all their nuances unless they are as concerned about delirium and ICU-acquired weakness as they are about falls and self-extubations. They need to understand and they need to hear it from survivors so they don't see patients as sleeping anymore, so that they're desperate to get them awake and communicating and mobilized. It's a huge culture change. And I think one of the gaps throughout the years is that we have not adequately educated our staff. Anyone that treats a patient in the ICU has to understand these principles.
I think that's great. Let's rapid fire a couple of these myths, hopefully bust a few of them.
Sure.
And then I want to talk about how you implement that change. So myth number 1, the team trial showed that ambulation isn't effective. By the way, I collected these from like social media responses. So these are like real myths that people are spouting.
Well, we already have the team trial,
Yep.
Not much contrast between the intervention and control group. There's a lot to learn from it. Absolutely. That this was not early or even super aggressive mobility. So what can you take away?
Low dose, way too late. No surprise it didn't work.
Yep.
Love it. Okay, myth number 2. It's impossible to safely ambulate patients who are intubated.
All the things that we mentioned, all the studies, check the citations.
Yeah, that's like the 1980s call. They want their belief back.
I mean, every daily level of increase in mobility decreases the risk of VAP by 40%. So again, it's unsafe not to. And you look at all those adverse events in that 0.6%, hypertension, hypoxia, falls, self or unplanned extubation was one of the very least frequent events.
Great points. Yeah. Okay. Anyone well enough to ambulate is probably ready for extubation anyway.
Yeah. I alluded to this earlier.
Yeah. We've got to see the ventilator as a walker. It's just another tool to facilitate mobility for most patients. So we don't bat an eye at going from 4 liters nasal cannula to 6 for mobility. Same thing on a ventilator. During COVID, if patients were not able to mobilize even on BiPAP because of their poor reserve or because of their hypoxia, that was a trigger to intubate them. Even if they could sit perfectly still and have subpar but okay oxygenation, we would then intubate them so that we could mobilize them. That's how important mobility was. We just increased the level of support. That's what the ventilator is. So again, I've walked patients on a PEEP of 18 and 100% on mechanical ventilation while intubated, but that's because we were walking them at day 1. They were strong enough they could tolerate it. We were watching them closely throughout. And a lot of times that prevented them from having to be prone and paralyzed. But if they did have to be, we'd take a break for that. For pronation and paralysis during COVID, that happened, absolutely. But then once they could be supine, then we were doing awakening trials to see, can they oxygenate with movement? Once they could, sedation was off. There was no longer an indication for sedation. And where they were back on their feet, mobilizing again.
Great. It's impossible to safely ambulate people with mechanical circulatory support or ECMO.
I would say a vast majority of teams are mobilizing. I did a podcast episode with a team that implemented their program during the Delta wave of COVID because I think up to 75% of their patients were dying. They felt like there's nothing to lose. They decreased mortality by 30%. So I don't think for many patients that there's a point in putting them on ECMO if they're not going to mobilize them.
Right. And I think that's a key point, which is that we're often picking people who have single organ failure as the ideal patients for these interventions. So then why are we causing other organ systems to fail with immobility?
Yep.
Right. Mm-hmm. Like we should be trying to keep every other organ system working. That's the whole point of this intervention.
And I've had patients from my Wake and Walking ICU, we didn't do ECMO. So even before COVID, if they got to the point of needing pronation paralysis and it wasn't getting better, we would promptly send them to an ECMO unit. We had an Awake and Walking ECMO unit in the University of Utah so that they could mobilize. That was the priority. We keep them walking as long as we could. And once they couldn't, we'd ship them over so that ECMO would get them back on their feet. It's just all in our perspective.
Yeah. And I think especially, not so much COVID here, but sometimes COVID, ECMO is sort of a bridge to something else. Mm-hmm. Like many of these patients, who just did not get much lung recovery would ultimately get like lung transplants, for example. Yep. And one of the biggest barriers to transplanting people who are on ECMO is their functional status and immobility. And so like, you don't know on day 1 whether this person is going to have a 3-day ECMO run or a 3-week ECMO run that's going to end in a transplant. And so give them the best chance you can by mobilizing them early.
How often did they fall off the transplant list because they no longer qualified because we left them in bed?
Right. Mm-hmm. Okay, 1 or 2 more myths here. In-bed pedaling is just as good as getting out of bed, but it's much safer.
We don't have any studies showing benefit to that. It's been tried. It's been studied over and over again because we love the concept of not having to get people out of bed, but there's nothing that can really replicate standing, bearing weight. We just don't see any benefit in any of the studies, unfortunately.
Yeah.
I think it's fine as an adjunct. I think it's fine if you've already walked them, you've already stood them at the side of the bed. If they want to do that, it's entertaining. I think that's fine. It's engaging. It just should not replace highest level of mobility.
Right.
I think one other, before we get to our closing, one other myth that you sort of dispelled earlier is this idea that it's too expensive, costly, resource intensive to implement this stuff, where it is the exact opposite. It's the lack of implementing these interventions results in increased cost.
I tell people, give me an hour with your executive leadership team, and they will see how they cannot afford not to support the teams in doing this. They need to be getting their checkbooks out and asking the team, what do you need to succeed? Because we can't afford this.
Love it. All right. So we've talked a lot about why mobility is important, but why sometimes, the idea of walking intubated patients is viewed as like sort of heterodoxic. How do you, when you go to a new place, how do you change the culture of this? Like, how does that happen?
It's important to meet them where they're at. So I have to get a sense of, where are they on the spectrum of compliance? Again, are they using versed drips and not mobilizing anybody? Or are they doing light sedation and mobilizing patients later on? Because if they are, even that takes a lot of skill and a lot of people. That tells me they probably do have the skill to do it. We just need to now focus on the timing. If they don't know how to do any of it, they don't have any mobility tools, no culture, then that's another place to meet them at. So I try to identify where they're at by looking at their data, meeting with each discipline, sometimes going on site early on and seeing for myself what's going on. Then I meet with each discipline of the ICU to talk about what their role is, give them clear instructions on RTs. Here's what I want your RTs to be focusing on. Here's your role. And making sure that every single member of the team participates in the webinars because they have to know the why. Because later I'm going to show up on site with a respiratory therapist and a physical or occupational therapist, and we run simulation training. And that's a waste of everyone's time if they don't know the why, because we've just got to practice the how. So we take their own case studies, someone pretends to be the patient, and we work together on critically thinking through and applying those principles from the webinar, practicing true mastery of the bundle together. And it's nice for them to see how it should have been, and then be able to say, but this actually in real life, you didn't mobilize this patient on day 1. You waited until day 11. And here's how much harder it was. And here's why they ended up with a tracheostomy. And not to make anyone feel bad, but they just see the reality of it. And then it helps them approach their next patients with a higher level of thinking and application.
Great. Yeah. And I think, one element I imagine is communication, right? So like that we just sort of make mobility part of the standard information that we convey to one another. What do you teach people about that?
I attend rounds with them, and I am listening to how they run rounds and what they ask about and how they talk about things. So for example, sometimes they're not even talking about CAM and RAS, and that's a low-hanging fruit. But if they are, then how do they respond to a positive CAM? If we have a elevated creatinine, we're stopping, we're asking pharmacy, where's the Vanco at? And we're looking at their fluid balance and all the things, try to figure out what's causing that. But when you have a CAM positive, everyone shrugs and they're like, yeah, so does the rest of the unit. And we move on. So we need to address it and make a plan and bring the team in to say, what are we going to do to treat this acute brain failure? RASA -1 is what's oftentimes reported, but I think it's important to ask, how are they communicating? If our goal of the bundle is to have them as awake and communicative as possible, why are they a RAS of -1? They can't hold a clipboard or text on their cell phone. They can't use the call light independently to say they have a sudden onset of chest pain. So shifting that focus to how are they communicating, also so the whole team approaches that patient ready to communicate with them and knowing what tool they use. So just adding things in like that. What's their baseline mobility? What tools do they use for mobility? What's our goal today? Those are things that are rarely talked about in rounds, but when we roll this out, it becomes mandatory.
Yeah, I think that's a big culture change too, which is that like some of the data that I expect to hear, even on nighttime rounds, is what is their mobility?
Yep.
One thing that I like that we implemented was signs on the door to sort of indicate on the Johns Hopkins scale what their mobility is. Yep. That way, the information is available both actively when it's presented and passively. It's like you walk by a room and you can see what this room's at.
CNA goes in there. They weren't there at rounds. They didn't get the RN handoff, but the patient wants to get to the commode. They need to know quickly if they can, what tool they use. We also should treat this like the sepsis bundle. Patient comes in after admission and we have timestamps. We know exactly when this happened, when this needs to happen. We should take the same approach to the bundle. They were admitted at this time. How long has it been since we've mobilized them? We need to have the same sense of urgency and communication about it.
Right. But no 30 mils per kg fluid bolus, please.
No more. That was, many moons ago.
Awesome.
Okay. And then one other thing we talked about was sort of like turning skeptics into advocates. Do you want to speak to that a little bit?
It's been one of my favorite parts of this journey to find people that are so adamantly against this become so passionate about it. A lot of times people are so hesitant because they're scared, because they care about their patients. They want to do what's best. They take a lot of pride in the quality of care that they deliver. It's hard to accept that we've done harm, and it's scary to change. But once they are pushed to the point of doing it and they see the benefit to the patient, I would say about 90% of these skeptics become the captains of the ship. These culture leaders can make or break this kind of initiative. And so it's been really fulfilling to see people that put my face on a dartboard and throw darts before I show up, and sometimes give us a hard time, but I just hang in there because I've seen so many of them become incredible assets to this movement. So I always tell people, don't give up on them. This could be a sifting. If they don't want to do this, they shouldn't work there. But a lot of times it's because they don't know how and they're scared to, not because they won't do what's best for the patient. There was a social media campaign amongst the nurses online to try to get my license revoked. That was a fun experience. So it just says a lot about the fear and the ignorance, really, that there is out there about this.
So I think we used this term earlier, and we were getting ready to record this term, ICU Revolutionist. What does that mean, and what does it mean to be one?
An ICU Revolutionist is someone that is doing anything, big or little, to revolutionize the critical care community and to create awake and walking ICUs. Anyone that's trying to combat delirium and ICU-acquired weakness, that's promoting a humanization of the ICU, is an ICU revolutionist.
Love it. Yeah, I think that's a perfect. I think it's a perfect moment to end our conversation on, which is just to say that like this is an area where we need to do so much better for our patients. Revolution is needed, and we need to do what we can to convince people of the importance of mobility and treating delirium aggressively. I think this has been just a fantastic conversation. Any other final points you want to make?
No, just go out there and revolutionize your ICU because lives depend on it.
Straight and to the point. I love it.
Yep.
So just another quick thanks for joining us. This has been an amazing episode. Where can people follow you on the different social media things? TikTok may or may not exist, as we're recording right now. It's January 20th, so who knows what the world's going to be tomorrow. But where can people follow you, and where can they listen to your podcasts?
They can follow me on any platform. They can look for Dayton ICU Consulting. On LinkedIn, it's Kali Dayton. There's also my business site is up there as well. The podcast is called Walking Home from the ICU on any main platform. My website is www.daytonicuconsulting.com. Therein you can find all the transcripts and citations from my podcast, and you can search by keywords. So if you want to hear from patients that have been sedated and immobilized to share with your team, you can look in those categories and you'll find many episodes.
Excellent.
Thank you, Kali, so much for your time. I know we, tried to wrap this up several times, but the content is just so solid. It's so important. And I feel like we could keep going, but, in the interest of your time and to kind of make sure that our audience doesn't completely drop off here, I think that, we did spend a good bit of time talking about why mobility, what is mobility really in the ICU, when mobility initiatives should be embarked upon, spoiler alert, as soon as possible. We talked about the costs associated with not implementing those initiatives. And then the interplay also between mobility, between ICU-acquired weakness, delirium, and, if you're a dollars and cents person, what is the real cost here? And the cost is significant. I think we also spent some time getting into the nuts and bolts of like, what are the tools of the trade? Who are the team members? And then finally, I think Nick kind of walked through some of the really important elements, which is like, okay, you got me, I'm sold. How do we implement this? And I think being that ICU revolutionist, and taking up that banner is like something that we all need to be seriously considering, because it's what's right for our patients. With that being said, again, Kali, thank you so much for your time. If you guys want to learn more about this, you should definitely check out her website, her podcast, and then please check out our website as well, where we're going to have show notes for this episode, for all our other episodes. That's www.criticalcaretime.com. Feel free to subscribe to our mailing list or leave a comment while you're there.
Yeah, we'd like to say a big thanks to all our listeners who come and visit our website, who subscribe to our newsletter, who give us comments and reviews on social media. I usually tell you guys to write us a review. This week, slightly different ask. Share the podcast with somebody. This is a really important episode. Send this podcast episode to somebody who has not listened to Critical Care Time before. That would be a huge help to us, and I think that would help the ICU revolution along. We'd love to hear from you. You can tweet or X at us at Crit Care Time, at Nick M. Mark, at Askins_Razor. Follow us on Blue Sky, Instagram, Threads, all of the platforms.
That's right. Exactly. And of course, we would also like to say a big thanks to our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes in season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system and acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
Also, big thanks to all the members of our production team who make this show possible, the production folks over at Podpaste, the music that you're hearing right now by Kurt Belknap. Thank you all very much. Quick disclaimer that this show is not the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking qualified medical advice. Thanks so much for listening, folks. I'm Dr. Nick Mark. See you next time.
And I'm Dr. Cyrus Askin. Thanks again, Kali, and we'll see you guys soon. Thank you.